In this video, I will be reading Thalassemia from the Ghai's 10th edition. I will be just reading and highlighting and making notes in the book in this PDF itself. And this video is for those who are feeling very lazy to read themselves. So here I am. Let's start. The major hemoglobin in children after 1 year of age is called as the HbA, constitutes approximately 90% of all the hemoglobin, while a minor component HbA2 accounts for 2 to 3%. So this is normal, right? After 1 year of age, HbA is 90%. And minor component HbA2 is only 2 to 3%. The main hemoglobin in the fetal life is HbF, of which only traces remain after 1 year of life. That is, HbF after 1 year is very low, only in traces. The word thalassemia is a Greek term derived from thala, which means the sea, and emia, which means related to blood. Thalassemias are hemoglobinopathies that occur due to mutations in the globin gene, and over 200 mutations are described. Beta thalassemia carrier rates reported in Indians varies in different communities from 3 to 17%. Thalassemia major is inherited as an autosomal recessive manner. That you should know that thalassemia major is an autosomal recessive. When a person carries a single gene mutation on only one of their alleles, they are called as the thalassemia trait or carriers, that we all know. When two persons with thalassemia trait carriers have a child, they may inherit the mutations from both the parents, resulting in mutations on both their alleles, leading to thalassemia disease. That can be intermedia or major. Okay, now coming to the pathophysiology. The homozygous beta gene mutation leads to an alteration in the rate of globin gene production. So there is a homozygous beta gene mutation that leads to alteration in rate of globin chain production. A decrease in the rate of production of the globin alpha, beta, gamma or delta impedes hemoglobin synthesis and creates an imbalance with normally produced globin chains. So there is a decrease in the rate of production of these globin chains, because two types of chains, alpha and non-alpha, pair with each other at a ratio close to 1:1 to form normal hemoglobin. The excess of normally produced type is present, and this accumulates in the cell as an unstable product, leading to early destruction of red blood cells before their usual 120-day lifespan. So what is happening is, with one alpha combines a non-alpha in the ratio of 1:1. So if there is a decrease in the rate of production of globin chains, this ratio is altered. So there is excess of normally produced type is present. Like alpha is normal in this, so alpha will be more, and this accumulates in the cell as an unstable product, which leads to the destruction of red blood cells. Okay, because of alteration in this ratio, there is destruction of red blood cells before their 120-day lifespan. The type of thalassemia usually carries the name of underproduced chain or chains. The reduction may vary from slight decrease to complete absence. What this means is, like if the name of the disease is beta thalassemia, there will be decreased production of the beta chain in that disease. This was the meaning of that line. When beta chains are produced at a lower rate, the thalassemia is beta plus, whereas beta, I don't know what to produce it, beta naught or beta zero thalassemia indicates a complete absence of production of beta chains from the involved allele. The disease is inherited in a Mendelian recessive fashion. Carriers who are heterozygous for the mutation are easy to identify and screen, though they are asymptomatic. Homozygous thalassemia major occurs when two thalassemia carriers marry. There is 25% risk that they will have an affected child who inherits the mutation from both the parents. Like how the Mendelian system works, if both the parents are thalassemia trait, that is heterozygous, there is a 25% chance that the children will have both the recessive alleles and will have a thalassemia major disease. The risk can be zero if only one parent is carrier, or by doing prenatal testing of the baby at 10 to 12 weeks of gestation. Okay, so this was like even before the birth of the baby, if the screening is done at 10 to 12 weeks, so the risk can be identified and can be zero. Now coming to the presentation, infants with beta thalassemia major usually demonstrate no symptoms until 6 months of age. Okay, so we have a patient admitted in our ward with suspected beta thalassemia, but her age is, I think, 7 months. Okay, so in beta thalassemia major, this was all unrelated. Infant with beta thalassemia major usually demonstrate no symptoms until 6 months of age, when the beta chains are needed to pair with the alpha chains to form the HbA after gamma chain production is turned off. Okay, so till 6 months we know that HbF will be present, and HbF constitute of alpha and gamma chains. So after 6 months, gamma chains will be reduced. Now the alpha chains will bind with beta, and the beta chains are affected in this beta thalassemia. So you got it right. However, the condition may not be recognized because of the delay in the cessation of HbF production in some cases. Okay. So because the beta chains are abnormal, the HbF will continue to exist for some more time. So the recognition might be delayed. Symptoms of the severe anemia as intolerance to exercise, irritability, heart murmur, or even signs of frank heart failure may be present. Okay, that girl which I was talking about has severe anemia. Her hemoglobin was something 5.1 something. Severe anemia may be present, as intolerance to exercise, heart murmurs may be present, even signs of frank heart failure may be present. Okay, severe pallor and hepatosplenomegaly are always present. Okay, severe pallor and hepatosplenomegaly is always present. Bone abnormalities such as the frontal bossing and prominent facial bones and dental malocclusion are usually present. These features are present because there is extra medullary hematopoiesis, right? So bony abnormalities may be seen. Okay, and such as frontal bossing and prominent facial bones and dental malocclusion. Ineffective erythropoiesis creates a hypermetabolic state associated with fever and failure to thrive. Okay, due to ineffective erythropoiesis, there might be fever and FTT, that is failure to thrive. Icterus is usually not present initially, but at a later age, some patients have mild to moderate jaundice because of this hemolysis. Okay, icterus is usually not present initially, but maybe later stages, mild to moderate jaundice due to the liver dysfunction from iron overload and chronic hepatitis. Okay, so this is also jaundice also presenting because of the iron overload due to repeated transfusion. Hyperuricemia may be encountered. Okay, this was all that we read about the presentation. What we read was beta thalassemia is, I'm just reading the underline part. Beta thalassemia usually present after 6 months of age. There can be severe anemia, severe pallor, hepatosplenomegaly, bony abnormalities may be seen, which include frontal bossing, prominent facial bones and dental malocclusion, and due to ineffective erythropoiesis, there may be fever or failure to thrive, and patient may present with mild to moderate jaundice later due to liver dysfunction from the iron overload and chronic hepatitis. Okay, hyperuricemia may also be seen because of same reason, cells are destroyed and the DNA, something like that, no, DNA gets converted into, I don't know, I forgot, sorry. Spectrum of beta thalassemia disease. Thalassemia major. Let's talk about thalassemia major first. This condition is characterized by transfusion dependent anemia. Okay, transfusion, beta thalassemia major wali diseases are transfusion dependent. Onset is around 9 to 12 months. Splenomegaly, bone deformities, growth retardation, and what? Hemolytic facies in untreated or inadequately treated individuals. Okay, so whatever we read above is given again in major. All the symptoms will be present. Major is mainly transfusion dependent, so and there will be splenomegaly, bone deformities, growth retardation, and hemolytic facies in the untreated or inadequately treated individuals. Examination of the peripheral blood smears shows severe hypochromia. Okay, in PS we can see severe hypochromia, microcytosis, marked anisocytosis, fragmented red blood cells, polychromasia, normoblasts, and occasionally immature leukocytes. We know that, right? That microcytic hypochromic anemia is seen in mainly thalassemia and iron deficiency anemia. And to differentiate which one is iron deficiency, is this iron deficiency anemia or thalassemia, we see the RDW value. RDW value is increased in iron deficiency anemia, more than 13, and if less than 13, it is most probably thalassemia. Okay, so in PS, what we are going to see: hypochromia, microcytosis, that is microcytic hypochromic anemia, and isocytosis will be present, fragmented red blood cells, because there is destruction going on. No, we saw, and polychromasia, that is different RBCs will have different level of hemoglobin. Normoblasts may be seen, and occasionally immature leukocytes. Organomegaly is mild in well transfused patients but is moderate in patients receiving irregular or inadequate transfusion support. Okay, so if the transfusion is not regular and inadequate, splenomegaly will be more, organomegaly will be more. Okay, now come in. This was all about thalassemia major. I don't think so this was enough, but okay, fine, let's go further. Thalassemia intermedia, also called as the non-transfusion. It is non-transfusion dependent thalassemia, present with anemia of varying severity, which may or may not require blood transfusion, usually presents after 2 years or even later in the life. Present after 2 years, okay, or even later. Icterus and splenomegaly will be present in thalassemia intermedia also. This is primarily a clinical diagnosis and requires monitoring of the child over time to see the clinical spectrum of the disease. Okay, blood levels of the iron and ferritin are raised. The condition may be found in compound heterogeneous state with inheritance of the two different hemoglobinopathies. This was tough to understand. Let's see. We saw that it is a clinical diagnosis and we have to monitor the child for the clinical spectrum of the disease, and the blood levels of the iron and ferritin will be raised, and the condition may be found in compound heterozygous state. I understand what's heterozygous, like both the alleles are different. What is compound heterozygous? If anyone knows, please let me know in the comment section. With inheritance of two different hemoglobinopathies. I couldn't understand this. Let's move further. Beta thalassemia associated with beta chain structural variants. Okay. The most frequent condition in this group is HBE disease. We are going to read about the beta thalassemia with beta chain structural variants. Okay, so what variants will be present in the beta chain? Most frequent is the HBE. These usually present with mild anemia and mild icterus. Patient with the HBE/beta thalassemia may present with the symptoms of anemia and organomegaly that we have been seen. Variability is seen because of the different genotypes, that is beta naught or beta plus. Co-inheritance of an alpha thalassemia gene, level of HbF, and the presence of other modifying genes. What does this mean? Let's see. The patients who will have HBE may present with symptoms of anemia and organomegaly, that will be present in all. Okay, variability is seen because of different genotypes. Okay, there are different types of genotypes, beta naught or beta plus, and variability is seen because of co-inheritance of the alpha thalassemia gene, that we know, right? And level of HbF and the presence of other modifying genes. These are the reasons which cause variability. Now coming to beta thalassemia, trait or minor. This was where we read beta thalassemia major. Now we are going to read beta thalassemia minor, and in between we read about beta thalassemia intermedia. Okay, now let's start with beta thalassemia minor. Patients have mild anemia, सब कुछ कम होगा. Mild anemia, microcytosis, and increased red blood cells number. The RDW is low. I told this previously. The peripheral blood film examination reveals marked hypochromia, microcytosis. There will not be anisocytosis, which is usually found in iron deficiency anemia. Okay. That's the reason why RDW is low, no? Because RDW tells about the level of anisocytosis only. Okay, so the peripheral blood film examination will show marked hypochromia, microcytosis, that is microcytic hypochromic anemia will be seen in beta thalassemia minor also. Okay, and there will be presence of target cells. Target cells are like these, showing the target in the center. This is basically very low hemoglobin in the RBC. High performance liquid chromatography, that is HPLC, or the hemoglobin electrophoresis shows the elevated level of HbA2 or HbF or increase of both. So what happens is in HPLC, by the HPLC shows the percentage of these HbA2 or HbF present. HbF, if it is beta thalassemia major, no, so it will be very high, and if it is minor, it will be very low. But HbA2 level in thalassemia is more than 3.5%. What is HbA2? HbA2 is abnormal type of, not abnormal, not HbA2 is hemoglobin with alpha 2 and delta 2, I think. Yeah, it's delta 2. And normal adult hemoglobin is HbA only, and HbA has alpha 2 and beta 2. Okay, and one second. HbA2 has alpha 2 and delta 2. Okay, so this is increased in thalassemia. Contrast in iron deficiency anemia and thalassemia trait is given this table. We will read. The diagnosis of thalassemia traits should be considered in any child with hypochromic microcytic anemia that does not respond to iron supplementation. Okay, so if we are giving in microcytic hypochromic anemia, we are giving patient iron and he is not responding, then we will suspect that it can be a thalassemia trait also. While this condition does not require treatment, patient and their families need to be counseled regarding the risk in the other family members and their progeny. Okay, like if they marry a thalassemia trait patient, they might have children with thalassemia major. Thalassemia major is not a very simple disease. The child needs recurrent blood transfusion monthly, and there will be iron overload, so they will need drugs like deferasirox and calfer. This is not a very good condition to be in. So this is very common. This thalassemia is very common in tribal areas. Let's move further. Read the table. Beta thalassemia trait and iron deficiency anemia. Okay, so symptoms in beta thalassemia trait will be absent and mild to severe depending on the degree of iron deficiency. Hemoglobin is usually 10 to 12 in trait and less than 10 in iron deficiency anemia. MCV is low in both because they are both microcytic hypochromic, but in beta thalassemia trait, MCV is less than 80, MCH is less than 27. Here very low MCV, less than 80. Less than 80 was present in both, but in iron deficiency anemia, very low MCV. Red cell count is elevated. Oh, this is a differentiating factor. Red cell count is elevated in beta thalassemia trait, and in iron deficiency anemia, red cell count is reduced. Red cell count is elevated maybe because there is increased destruction of the RBCs in beta thalassemia trait. No, I mean a little destruction will be present, so red cell count is increased. Red cell distribution width, I told you that it is more in iron deficiency anemia. How to remember is RDW is increased in which the longer name is present, like iron deficiency anemia, RDW is increased. Very lame trick, but that works for me. Serum iron and ferritin is normal in beta thalassemia trait unless concomitant iron deficiency, and in serum ferritin will be low in iron deficiency. Basic common sense. HbA2 levels on the HPLC are increased in beta thalassemia trait. I told you that in all types of thalassemia, whether major or minor, HbA2 levels will be increased only. Okay, and HbA2 levels will be normal in the iron deficiency anemia. So maybe borderline low and missed, especially with the concomitant iron deficiency, which lowers the HbA2 levels. Iron deficiency also lowers the HbA2 levels. This is for the first time that I read this. Okay, now let's read about this image. Peripheral smear from a transfusion-dependent patient with a beta thalassemia major showing marked anisopoikilocytosis. How I remembered was in P, poikilocytosis, there is something called anisopoikilocytosis. There are two terms. It is a mixture of two terms, anisocytosis and poikilocytosis. As P starts as P, we can remember shape. Shape also has P. So there is difference in the shape in poikilocytosis. Different shapes of RBCs are present. In anisocytosis, there is no P, so there will be no P in the word also. There is size. Aniso means size, different sizes of a RBC. So if anisopoikilocytosis is present, different shape and size. This was just a lame trick to remember again. Microcytosis is seen, right? There is a microcytosis. Obviously, small RBCs are seen. See, lots of small RBCs. Hypochromia, polychromatophilia, nucleated red blood cells. Where is nucleated red blood cells? Oh, I can see the nucleus now. Yeah, this is nucleus. This is the nucleus. Right. Polynucleated red blood cells and few fragmented erythrocytes. Fragmented erythrocytes are also seen. Okay. I think this one is the fragmented. This one is fragmented. Yeah, schistocytes. This one is a fragmented RBC. Let's move further about the laboratory studies. The complete blood count and peripheral blood film examination results are usually sufficient to suspect the diagnosis. Okay. CBC and PS is sufficient to suspect the diagnosis. The thalassemia major or intermediate, the hemoglobin level ranges from 2 to 8 gram per deciliter. MCV and MCH are significantly low. Reticulocyte count is elevated to 5 to 8%. Okay, reticulocyte count is elevated to 5 to 8% and leukocytosis is usually present. A shift to left is also encountered. Okay, a shift to left is also encountered, reflecting the hemolytic process. The platelet count is usually normal unless the spleen is markedly enlarged and causing hypersplenism. Okay, so what is written is platelet count is usually normal unless the spleen is very large. Okay, fine. So what we saw was there was MCV and MCH are significantly low. Hemoglobin levels are in the range of 2 to 8 in major and intermediate, and there is shift to left, and there is leukocytosis is usually present, and reticulocyte count is elevated in between 5 to 8%, and the platelet is usually normal unless there is hypersplenism. Peripheral blood film examination reveals marked hypochromasia and microcytosis, polychromatophilia. This all is repeating. Nucleated red blood cells, basophilic stippling. This was new. Basophilic stippling. And occasional immature leukocytes. A sample must be sent for the high performance liquid chromatography, that is HPLC, prior to the first blood transfusion. Right. This confirms the diagnosis of beta thalassemia disease states. There is absence of HbA and elevation of HbF. The level of HbA2 is not needed for the diagnosis of thalassemia major. Okay, so in thalassemia major, what happens is there is absence of HbA, adult normal hemoglobin. HbA is the normal adult hemoglobin, which is absent. HbF is elevated, and the level of HbA2 is not needed for diagnosis of thalassemia major. Okay, or intermediate also. The demonstration of elevated HbA2 fraction is important to identify patients with thalassemia trait. Thalassemia trait वाले patients में HbA2 will be important to demonstrate that this patient has trait. Options for management and common complication. Genetic counseling is needed for family to prevent the birth of other children with thalassemia major. Prenatal testing to see if the fetus is affected can be done by the chronic villus sampling at 10 to 12. Okay. So by CVSS, chorionic villus sampling at 10 to 12 weeks, we can test the fetus to check if the fetus has thalassemia major or not. Blood transfusion should be initiated at an early age if the hemoglobin persists below 7 gram per deciliter on a regular transfusion therapy. Attempts to keep the pre-transfusion hemoglobin between 9 to 10 gram per deciliter. That is, before transfusion, hemoglobin should be maintained between 9 to 10 gram per deciliter to promote the growth and prevent any deformity. Chelation therapy to deal with the accumulated iron is vital to prevent the iron overload that we talked about. And organ dysfunction. Iron preparation should not be given to patients with thalassemia, intermediate or major. Okay, iron preparation, there is iron folic acid tablets should not be given. Okay, like if we suspect that there is microcytic hypochromic anemia and we made the wrong diagnosis of iron deficiency anemia and we start the patient on iron, but I don't think so this will happen, because iron overload occurs after blood transfusion. No, right, I was talking shit, ignore that. Iron preparation should not be given to patients with thalassemia, intermediate or major. Should not be given. Okay, a normal diet is recommended with the following supplements. What we can give in thalassemia patient is folic acid. Yeah, right, folic acid is given. Small doses of ascorbic acid, vitamin C and alpha tocopherol. I have no idea why vitamin E is given. If anyone knows, please let me know. Drinking tea with the meal has been shown to decrease absorption of iron from the gut. Stupid faltu ka fact. Let's move further. The introduction of hematopoietic stem cell transplantation offers the possibility of cure of thalassemia major patients. Okay, so thalassemia major patients can be cured by hematopoietic stem cell transplantation. Early transplant before the onset of complication has best results. Obviously, therapy of non-transplanted children consists of regular blood transfusion and iron chelating agents. If the both are pursued vigorously, it will allow these children to survive into adulthood with the fewer complications. What this meant was, therapy of non-transplanted children consists of regular blood transfusion. Just wait. Sorry, I was zoned out. What this means is, in patients who are not undergoing any bone marrow transplantation, so in that we have to give regular blood transfusion because hemoglobin will be decreased every few days, and iron chelating agents. And if both are given adequately, pursued vigorously, it will allow these children to survive into adulthood with fewer complications. Medications like hydroxyurea and luspatercept are effective in thalassemia intermedia and some patients with thalassemia major also. I have not seen patients with thalassemia having hydroxyurea. This was new. And hydroxyurea and luspatercept. This was very new drug for me. Okay, let's go. Oh, and about me, I have just started residency. I'm just an MBBS pass out. I've started residency a few months back. So moving further, blood transfusion reactions and infections. After multiple transfusions, patient may develop transfusion reaction. We all know that. I was just trying a cursor. Wait. I was searching for cursor so that you can follow where I'm reading, but I don't know how to. Let's move further. Starting with blood transfusion reaction and infection. After multiple transfusion, patient may develop transfusion reaction or alloimmunization to red cell antigens. These complications can be minimized by using This transfusion reaction can be minimized by using leukocyte filter during the transfusion, or better still by having the blood bank preparing leukocyte depleted pegged red blood cells. Okay, so in PRBC, if the leukocytes will be reduced, then there will be less transfusion reactions. Administration of acetaminophen and diphenhydramine hydrochloride before each transfusion will minimize the febrile or allergic reaction. This was very new for me. Let's see, acetaminophen is PCM, no. And diphenhydramine hydrochloride, wait. It is an antihistaminic, no. So, if before administration of PRBC, we give acetaminophen and any antihistaminic, so transfusion reaction will be minimized. The major complication of blood transfusion are those related to transmission of infections, right? There might be risk of transmission of hepatitis B, C and HIV, although the blood is screened properly before that, but still there is a risk, no? What if the screening was not proper? These can be reduced by good blood banking practices, hepatitis B vaccination and regular assessment of the hepatitis and HIV status as a part of routine care. Lactoferrin, a prominent component of the granules of polymorphonuclear leukocyte, is bacteriostatic for pathogens. The high transferrin saturation in patients with iron overload compromises the bacteriostatic properties of the protein. What we are reading is, there is a component called as the lactoferrin present in the leukocytes, polymorphonuclear leukocytes, which is bacteriostatic for pathogens, but due to the high transferrin saturation in patients with iron overload wale mein, the bacteriostatic properties of this protein are compromised. So infection with the Yersinia enterocolitica can occur in iron overload patients and presents with the fever and diarrhea. Okay, so if any patient with who is having any blood transfusion present with fever and diarrhea, you have to suspect infection with Yersinia enterocolitica. Okay, these patients are treated with gentamicin and cotrimoxazole. Other important infections which may occur are mucormycosis and Listeria monocytogenes. Okay, Yersinia, and then with fever and diarrhea, and mucormycosis by Rhizopus oryzae and Listeria monocytogenes. Iron overload. Let's start with iron overload. Iron overload is the major cause of morbidity and organ toxicity. Okay. Excessive iron is due to increased gastrointestinal iron absorption as well as repeated transfusion because of repeated. Okay. Patient with the iron overload demonstrate endocrinopathy caused by iron deposition in the organs leading to hypothyroidism. Iron overload वाले patients में there will be iron deposition in organs जिसकी वजह endocrine organs में भी leading to hypothyroidism and decreased growth and lack of sexual maturation, diabetes mellitus and hypoparathyroidism because of iron overload in different organs. Death is secondary to cardiac or hepatic iron overload. In older patients, bone and renal problems may also occur. Fine, because of this, all problems were occurring because of iron overload, because of iron depositing in various organs. Iron status is monitored by serum ferritin measurements. However, liver and the cardiac iron may be underestimated by this test. A highly accurate and non-invasive tool to assess the iron status is the cardiac T2 magnetic resonance imaging. So if we want to check how much iron is present in the heart, we can do what? Cardiac magnetic resonance imaging. T2. That also T2. This can predict cardiomyopathy up to 2 years prior to the presentation and enabling the effective iron chelation therapy. Okay, so we can predict 2 years prior to the presentation of cardiomyopathy, and we can start effective chelation therapy. Now coming to the chelation therapy, the introduction of chelating agents capable of removing the excess iron from the body has dramatically increased the life expectancy, right? The drugs that I told, deferoxamine. Let's see. Combination therapy may be needed in some children not controlled by appropriate usage of single iron chelator. The optimal time to initiate the chelation therapy is dictated by the amount of accumulated iron. This usually occurs after 2 to 3 years of transfusion or when the serum ferritin level is above 1000. So when we have to start the iron chelation after 2 to 3 years of transfusion or when the serum ferritin level is more than 1000 microgram per liter. The gold standard was deferoxamine, but this has to be administered by prolonged subcutaneous infusion due to its short half-life. DFO total dose was 40 to 60 mg per kg per day, is infused over 8 to 12 hours for 5 to 6 days per week by a mechanical pump. Patients should be warned that their urine will become orange due to the iron deferoxamine complex being excreted. Eye examination, hearing tests and kidney functions are required to monitor the effects of deferoxamine therapy. तो अब तो इसको नहीं करते ना, इतना कुछ करना पड़ रहा है, ऊपर से आई भी देना पड़ रहा है. डेफ्रासिरॉक्स जो है, दैट इज़ द ओरल chelating agent. So this is most commonly used now. The molecule is trident ligand that binds with the iron with high affinity, forming 2:1 complex that is excreted in the bile and eliminated in the feces. Okay, so this works by eliminating the iron in the feces, by binding to that iron and eliminating it in the bile and feces. It is highly selective for iron, chelating both the intracellular and extracellular iron throughout the body, liver, heart and reticular endothelial system and circulation. It may cause skin rashes, nausea, vomiting, renal or hepatic toxicity. Oral drug is also causing these type of side effects like skin rashes, nausea, vomiting, renal or hepatic toxicity. Monitoring of creatinine, liver function tests and urine for the proteinuria is required. The recommended starting dose is 20 to 30 mg per kg per day. This is important. for me. And for those who are in PG, we have to start the Defraserox in the dose of 20 to 30 mg per kg per day. Deferiprone, another oral agent, though effective for removing cardiac iron, might cause cartilage problem, neutropenia and even agranulocytosis. So why will we give this? We will not give this. We will give Defraserox. The spleen acts as a store for non-toxic iron and its early removal may be harmful. Splenectomy is justified only in hypersplenism leading to excessive destruction of the erythrocytes and increased need for the frequent blood transfusion, which results in further iron accumulation. So patients who require more than 200 to 250 ml per kg of the pegged red blood cell per year to maintain hemoglobin may benefit from this procedure. So what is written is splenectomy should not be done in all because there is non-toxic iron storage in that spleen. Okay, so patients who require more than 200 to 250 ml per kg of the PRBC per year to maintain the hemoglobin, they may benefit from this splenectomy. Pre-splenectomy immunization and prophylactic antibiotics significantly decrease the post-splenectomy infections. We know, right, that after splenectomy there is increased risk of infections by capsulated organism. I think I'm right. If I'm wrong, please let me know in the comments. The procedure is delayed until the child is 5 years or older. This splenectomy procedure is delayed until child is 5 years. Okay, now coming to the complications. Let's start. First complication is bone problems. The classic hair on end appearance of the skull results from the widening of diploic spaces. Diploic is like diplopia, no? Eye is related. This is diploic spaces between the two bone tables of the head. The maxilla may overgrow, resulting in the maxillary overbite and prominence of the upper incisors. These changes contribute to the classic hemolytic facies. I think chipmunk facies. Observed in the patients with thalassemia major, bone density problems increase with the age. The osteoporosis and osteopenia will require treatment with the vitamin D and bisphosphates. Yeah, right. We give calcium to most of these thalassemia major patients also. Right, osteoporosis and osteopenia may occur, so we have to treat with vitamin D and bisphosphonates. Extramedullary hematopoiesis is another complication. This usually occurs in patients with thalassemia intermedia, but can occur in thalassemia major in those who are not receiving adequate transfusion therapy. Compression fractures and prevertebral expansion of the extramedullary masses, which behave clinically like tumor, may occur during the second decade of life. What happened here was, this extramedullary hematopoiesis was occurring in thalassemia intermedia because in major we give transfusion, so there is no need of extramedullary hematopoiesis. But if the transfusion is inadequate, then this will occur extramedullary hematopoiesis, and there is risk of compression fractures and paravertebral expansion also because of expansion of extramedullary mass, which sometimes clinically behaves like tumor and may occur during the second decade of life. Okay, psychosocial issues. As these children are surviving into adulthood, newer problems related to employment, marriage and having families, as well as the stress of chronic illness will be needed to be addressed. Patients with thalassemia, hemophilia, sickle cell disease are recognized as disability under the Right of Person with Disabilities Act 2016. Right. In our district hospital, we give disability certificate to these children also. This is like they are not actually disabled, but their life is very much compromised. No, see, they'll have blood transfusion monthly. They'll have to go to a hospital, get admitted there, get blood transfusion and get monitored. This will require 2 to 3 days, sometimes even more, of their monthly these days. So they need some disability, right? Disability benefits. Coming to the curative therapy, hematopoietic stem cell transplant or the allogenic bone marrow transplant from the HLA-matched sibling is curative. Right. Hematopoietic stem cell transplant from HLA-matched sibling can be curative. A government program in partnership with the Coal India Thalassemia Bal Seva Yojana covers the cost of patients who are suitable and most likely to benefit from such procedures. Novel therapies like gene therapy and gene editing are being tried in clinical trials. Thalassemia intermedia patients require monitoring to assess the need for transfusion, and persistently low hemoglobin may retard the growth. Okay, so hydroxyurea at dose of 10 to 20 mg per kg per day may be used in attempt to increase the HbF production. Okay, hydroxyurea, right, it is one of the mechanism of action of hydroxyurea that it increases the HbF production and reduce the need for transfusion. So hydroxyurea may be given in patients with thalassemia intermedia. This therapy is most effective in those children with XLM1 mutation. Iron overload is a problem due to its increased absorption. Chelation is required if the serum ferritin is more than 1000 microgram per liter. We already read this. Now coming to the prevention of thalassemia major, the last topic. Persons with thalassemia trait do not require medical follow-up after the initial diagnosis. Iron therapy should not be used unless a definitive iron deficiency is confirmed. Genetic counseling is indicated to create awareness and prevent thalassemia major in subsequent offspring, right? Genetic counseling need to be done. Prevention program of the National Health Mission advocates awareness and screening of adolescents to make them aware of their carrier state so they can choose their future partner, right? So if a person is carrier, the partner whom he or she is marrying, they should get checked so that the other person is not a carrier. Otherwise there is chance of the children having a dominant disease like thalassemia major. Antenatal testing of the thalassemia carrier state of mother is important. The option of prenatal testing should be given if both the partners are thalassemia carriers. Okay, done. Thank you.